Good morning, everyone, and welcome to this presentation on monitoring modalities in TBI. We are going to discuss the hemodynamics part of the monitoring modalities. My name is Joanna Berger-Estilita. I work in Switzerland. I'm an anesthetist and intensivist in Bern, and I also am a researcher at the University of Bern. I first of all would like to thank the University of Health Sciences International Anesthesiology and Reanimation Symposium organization, particularly Professor Dr. Mehmet Gamli for organizing the symposium, and to Professor Ayten Sarakoglu for the kind invitation to have me here. These are my conflicts of interest. None of them will be important in what I'm going to tell you today. And let's start. So cerebral metabolism is highly active and requires around 20% of the body's oxygen, while represents only 2% of a person's total body weight. So cerebral blood flow complies about 18% of the cardiac output and generates around 50 milliliters of per 100 grams of brain tissue per minute. The brain itself has absolutely almost no energy reserve, and it's completely dependent on blood flow. So this suggests that the brain is highly vulnerable to hypoxia and hypoperfusion. As you know, TBI affects around 69 million of people worldwide each year, and it's a disease with a wide spectrum of severities, etiologies, and outcomes. The complex and still evolving understanding of the pathophysiology of TBI as it progresses from primary brain injury through insult, from subsequent cascades of secondary brain injury combined with individual intervariability in cerebral autoregulatory capacity, makes it very difficult to establish hemodynamics parameters to ensure an optimal cerebral perfusion. Traumatic brain injury is the leading cause of death and disability before the age of 45. And as you can see here, the pathophysiological cascade that follows includes cerebral edema, intracranial hypertension, inflammation, increased sympathetic tone, and catecholamine surge in response to brain injury. All of these may affect different organs simultaneously and lead to their failure. So why do we monitor the injured brain? Well, first of all, prevention of secondary brain injury is key in neurocritical care. There are several types of disruptions that can occur: mass effects, ICP elevation, inflammation, disruptor of the brain, the blood-brain barrier, dysfunctional autoregulation, and even disruption of flow to drive injury. So injuries that lead to regional or global ischemia and tissue hypoxia can all cause cell death. And cell death in the brain is relatively difficult to deal with. And finally, patients at the higher risk are usually those that are more severely injured and have limited clinical examinations. Therefore, objective monitoring of cerebral physiology and function is absolutely critical. To function, the brain requires an adequate delivery of nutrients and oxygen. This is the hemodynamics part. The circulatory system is therefore required to maintain an optimal cerebral blood flow for the brain's diverse needs. Whilst oxygen and nutrient delivery is in part dependent on the pump supplying it, which is the heart, the circulatory system has also evolved mechanisms to ensure that precise control of CBF, of blood flow. The cerebral vessels have a remarkable ability to rapidly adapt and react to the brain's chemical environment and to neuronal signals and to the pressure within the cerebral vessels. So as you can see, there are a lot of influences and determinants of cerebral blood flow. We have an arterial component, a resistance component within the brain, and the ICP. So intracranial pressure, or ICP, is the pressure that is exerted by fluids such as the CSF, the cerebral spinal fluid, inside the skull and the brain tissue. ICP is usually measured in millimeters of mercury, and at rest is between 7 and 15 for an adult. Physiologically, ICP is a function of intracranial compliance. Intracranial compliance, as you can see on the left, is the relationship between the ICP and the volume of the intracranial cavity, including the CSF, brain tissue, arterial and venous volume. Because the skull is a fixed and rigid anatomic space, ICP will increase as intracranial volume increases and intracranial compliance decreases. There is the formula for the CPP, which is the cerebral perfusion pressure, which is the MAP minus the ICP. So as we calculate the CPP, the cerebral perfusion pressure, we actually use that as the cerebral hemodynamic parameter of choice. But for that, we require to measure both the MAP and the ICP. The MAP we can measure directly through invasive monitoring and hemodynamic means, most often an arterial cannulation of a peripheral artery. And the MAP can also be measured indirectly with a non-invasive blood pressure cuff. ICP, we can usually directly measure via an intracranial pressure transducer ICP monitoring, which makes sense from a pathophysiological standpoint, as it affects cerebral perfusion pressures and it can precipitate or worsen hypoperfusion and ischemic injury. Data from larger observational studies suggest that the threshold of ICP that is more than 20 will create harm. And several meta-analyses of studies have shown this to be associated with worse outcome. In this small study, which is rather recent, the researchers investigated the connection between the physiological parameters measured through the intracranial neuromonitoring and neurological outcomes in patients with hypoxic ischemic brain injury. They retrospectively analyzed data from patients who underwent ICP monitoring, brain tissue or oxygen monitoring over a 3-year period. And the results showed that patients with unfavorable outcomes had higher ICP compared to those with favorable outcomes. So ICP seems to be able to discriminate between favorable and unfavorable outcomes as well. But basically, the study concludes that intracranial pressure is associated with neurological outcomes in TBI patients. Other recent studies, including this one from the New England, suggested that ICP monitoring was associated with a lower rate of survival and worse functional outcome. This is the only randomized clinical trial to compare ICP-based treatment protocols with a treatment threshold of 20 versus a conventional one with ICP monitoring for TBI. This was conducted in South America because there was a lack of clinical equipoise in the USA, and it basically showed no difference in functional outcome between both groups. But it does show, however, that the clinical examination and the imaging-driven protocols seem to be as good as ICP-driven ones. In this recent cohort study, they aim to assess the impact of ICP monitoring on short and midterm outcomes for traumatic brain injury. The study involved almost 1,500 patients from 43 intensive care units across Italy and Hungary, and patients who met the Brain Trauma Foundation guidelines for ICP monitoring were divided into those who underwent monitoring within 2 days of injury, so the so-called exposure group, and those who were not monitored or were monitored 2 days after the injury. The main outcome measure was functional disability at 6 months. That was assessed by the Glasgow Coma Scale Extended, the GOOSE scale. And the findings indicated that patients who underwent ICP monitoring had a lower 6 months mortality, better neurological outcome at 6 months. And obviously, this group had a more intensive therapeutic approach. So this study suggests and goes against many of the findings of the New England Journal of Medicine paper, and sort of like gives it another light to the ICP monitoring as a benefit for the patients. Finally, this study in the JAMA network, also very recent, they aimed to refine the understanding of a normal ICP value and identify the ICP threshold most strongly associated with outcomes in neurocritical patients. The findings suggest that ICP values of H2 night are most commonly recorded and could possibly represent the normal values. These ICP values greater than 19 were associated with higher mortality, while the lower values were associated with better outcomes in surviving patients. And obviously, the findings contributed to the ongoing efforts to better understand the relationship between ICP and patient outcomes. Regarding the Brain Trauma Foundation guidelines, so all of this new evidence seems to validate the Brain Trauma Foundation guidelines for ICP monitoring for TBI, which still includes to this day a clear indication for ICP monitoring in patients with a Glasgow Coma scale with 8 or less, and CT evidence of ICP elevation with a target of an ICP below 20 to 22 millimeters of mercury. These are grade 2B recommendations, so there is low quality of evidence, but the evidence seems to be accumulating. Another cerebral hemodynamic parameter that is worth mentioning is the cerebral autoregulation. In normal conditions, cerebral autoregulation ensures that cerebral blood flow is unchanged despite variations in blood pressure by regulating the cerebral vessels. For example, if the blood pressure increases, the cerebral vessels vasoconstrict to keep the cerebral blood flow normal, whereas a decrease in blood pressure would lead to vasodilation of the cerebral vessels to increase blood flow. So these cerebral vascular reactions to changes in blood pressure generate a corresponding effect on the intracranial pressure. So according to the Monro-Kelly doctrine, less cerebral blood volume leads to a reduction in the intracranial pressure. So when intracranial compliance is limited, as we can see here, small volume changes affect the ICP dramatically. And when autoregulation is altered, pressure changes affect directly the blood volume. This is important in the injured brain because, as you can see, the autoregulation in the injured brain is much, so the interval is much shorter and you have much more interval of dysregulation. The clinician at the bedside needs to decide whether we would go for an ICP or a CPP-oriented therapy, as these often call for different management strategies. CPP-driven protocols require assessment of cerebral autoregulation and monitoring of the ICP response to MAP. And we have, I brought you these two papers, one of them from Rosner and colleagues that reported favorable outcomes. Patient TBI cohort treated using volume expansion, ventriculostomy, drainage, mannitol, and pressors using the CPP goal of over 70. This is an old study, but it was then validated later by an RCT conducted by Robertson, again on a cohort of TBI patients, comparing ICP versus CPP-driven treatment protocols, and found that the group with CPP over 70 had less ischemia when measured by jugular venous saturations. As you know, the CPP, or the cerebral perfusion pressure, is the MAP minus the ICP. For obvious ethical reasons, active blood pressure manipulation to identify the effects of systemic hypotension on TBI outcomes have still yet to be studied, but nonetheless, all the observational studies over the last 30 years have consistently identified that systemic hypotension is a predictor of poor outcomes in TBI patients. Regarding the optimal CPP, the Cogitate phase 2 RCT in TBI compares clinically the CPP targets of 60 to 70 with the optimal CPP for each patient. This study is currently ongoing, but a recent Delphi consensus on CPP targets on TBI demonstrated that CPP should be individualized to each patient. Obviously, we need more research to validate individualized and dynamic targets, or CPP targets. And unfortunately, at the moment, there is no specific recommended module for measuring cerebral autoregulation. However, there are multiple modules that have been investigated to assess cerebral autoregulation, including these ones in the table here. So they use arterial blood pressure, ICP monitoring, and sometimes flow velocities of cerebral arteries. One of these measures, which is the one that I highlighted in red, is called the pressure reactivity index, the PRX. So this pressure reactivity index, or PRX, is a tool for monitoring cerebral autoregulation in the intensive care setting for patients with brain dysfunction, traumatic brain injury, subarachnoid hemorrhage, etc., in order to guide therapy to protect the brain from dangerously high or low cerebral blood flow. The PRX uses a mathematical algorithm to calculate the correlation between arterial blood pressure and intracranial pressure. So patients, as you can see here on the graph, on the exponential part of the curve, which is part 2, have a poor compensatory reserve, meaning that a slow change in the volume of the intracerebral space can cause significant changes in the intracranial pressure. There was a single center that compared conventional ICP thresholds of 20 to 25 millimeters of mercury to ICP thresholds derived from the PRX graphs. And they found that there was a better correlation of prediction of death than the conventional threshold. So it's not just the indexes itself. There is a direct correlation with blood pressure and perfusion pressure in TBI. So first of all, there is this excellence in pre-hospital injury care, the EPIC TBI study. And they had a cohort of about 4,000 patients, 4,000 TBI patients, and they found a decreased odds ratio for death for every 10 millimeters of mercury increase in the lowest pre-hospital systolic blood pressure. An interesting finding of the study was the linear association observed between systolic blood pressure and mortality, suggesting that the historical cutoff value for hypertension, which is the 90 millimeters of mercury, may actually be inaccurate, and that there may be a meaningful, safe systolic blood pressure threshold for these patients. As a revised edition of the Brain Trauma Foundation guidelines was greatly influenced by this study, and another one from Berry that stratified almost 16,000 TBI patients into 3 age groups. So basically what they found is that an SBP higher than that was given the traditional definition of hypotension was required for TBI patients. This means that for patients between 15 and 49 years old, the optimal threshold is a systolic blood pressure of 110. And for patients aged 50 to 69, the optimal blood pressure would be 100 millimeters of mercury for the systolic blood pressure. And again, 110 for the age group 70 or older. So importantly, these observational designs of these studies allow for determination of associations, not causations, but in light of new evidence, the BTF then subsequently revised the target blood pressure recommendation and now gives a level 3 recommendation to maintain a systolic blood pressure above 100 in patients aged between 50 and 69, and above 110 for those age groups between 15 and 49 and over 70. I would like to address this important concept, which is the brain-heart crosstalk that has been studied for decades since the Cushing reflex was described. And in this regard, the reciprocal crosstalk between the cardiovascular and the cerebrovascular systems exists and consists of several different, and the brain-heart crosstalk plays here a crucial role in the development of cardiac dysfunction, which, along with pulmonary issues, is a frequent extracranial consequence in TBI patients. So the cardiovascular system's effects on the central nervous system are now known, and they've involved factors like hypotension, edema, and even embolic strokes. And there are also cerebrovascular events that can lead to cardiac problems, such as enzyme release, arrhythmias, ischemia, and cardiac failure. These changes are often associated with abnormal catecholamine exposure, and which results in the release of epinephrine or adrenaline, and they cause these stress-related cardiomyopathies that we see both in trauma and in other stress-related situations as well, like, for example, in sepsis. These cardiomyopathies can affect cardiac function in various ways, and they impact the heart rate variability, the baroreceptor reflex sensitivity, the intracardial conduction, and they can cause acute myocardial dysfunction. So in cases of cardiac failure, the inadequate hemodynamic state may fail to meet cerebral metabolic demand, worsening neurological status and lead to unfavorable outcomes. So it is crucial that although we are monitoring parameters on the brain, we need to consider extracardiac sources of myocardial abnormalities after excluding primary cardiovascular sources. So to conclude, there is no single measurement that can optimize outcome at this moment. What we need is a comprehensive care that incorporates both the clinical experience and multiple data points. That may be the best way to measure and optimize outcome. We have several indexes like the PRX, the optimal CBP that hold a lot of promise in TBI, but we still need a lot of pragmatic trials to test real-life relevance of monitoring strategies and associated management. In conclusion, both low and high systolic blood pressure are identified as detrimental for the injured brain in TBI patients. Preventing or minimizing pressure fluctuations is absolutely fundamental in TBI management. Early hypotension, often originating from associated injuries like myocardial contusion, extracerebral bleeding, or secondary polyuria, significantly increase mortality after TBI due to compromised cerebral perfusion. Prompt and aggressive hypotension reversal is recommended, targeting systolic blood pressure to 100 or 110, as we've seen. Hypertension may initially be neuroprotective, but may lead to secondary brain injury through sustained catecholamine release and increased blood pressure, as we've seen. This promotes cerebral edema. However, current guidelines do not specify an optimal pressure threshold for hypertensive TBI patients. And the combined multimodal monitoring, which includes cardiac outputs, ICPs, as we've seen, is probably the best and most effective way at the moment to enable all the required interventions that we need, optimize fluid administration, and manage vasoactive therapy. And my last slide, which is probably a linking slide to the following presentations, is regarding the mantle. So as you know, and in a broad way, oxygen is fundamental for neuronal survival. We have seen that in the beginning. The brain relies on a constant supply to produce its main energy source. And this supply is the delivery of oxygen, depends on sufficient cerebral blood flow and adequate arterial oxygen content. The brain monitoring is not a routine, and there's limited evidence base to support it. Authors have recently proposed the mnemonic, the mantle, which has not been validated yet, but it has been created to help clinicians remember which factors are absolutely essential for optimizing cerebral oxygenation in severe traumatic brain injuries, and which include all these aspects, not just the hemodynamic aspect, although the hemodynamics is contemplated in the algorithm. It just gives us a broader view of what we need to do to maintain oxygenation of the brain. And this is my last slide. I thank you so much for your participation and your attention, and I will be now answering some questions. Thank you so much.